Good morning, everybody. Thank you. Thank you. Very good. All right. Welcome to an MSU's News program. And yes, we are much different than other patient advocacy organizations out there. We are providing something that they are not providing, and that is these types of formats. This is my third program this week, so we're heading strong down the road this week. We want to thank those that support what we are doing, okay? And like today's program, we want to thank Celgene. All right, Celgene is a pharmaceutical company. They do not yet have an MS medication on the market, so they don't have anybody here to exhibit, but we all should, support, give them thanks for what they are doing, okay? Thank you. Additionally, we had some exhibitors here today. Mallinckrodt was supposed to be here. They got caught up in all this traffic. All right. Biogen was here, EMD Serono, and Genentech. And I want to thank them for helping out at today's program, too. Thank you. All right. For those that don't know me, well, I guess you haven't been around long enough. My name is Stuart Schlossman. I, too, have MS. We could talk about that another time. Today, we have three speakers, and we want to get started. All right, so our first is Jeffrey Siegel. And Jeffrey is going to be speaking for 35 minutes, and he's going to do 10 minutes of Q&A. After Jeffrey, we have urologist Dr. Harvey Samowitz. All right, and he will speak for about 35 minutes. And hold all questions that you might have for him, because after Dr. Samowitz, Dr. Kantor will speak. And after Dr. Kantor is finished, we'll then do a joint Q&A for the two of them at the same time, where I'll run around the room with a microphone. Our next speaker is the urologist, and maybe he could answer something about pelvic floor exercise, right? So Dr. Harvey Samowitz, he's a medical doctor. He's a fellow of American College of Surgeons, fellowship trained in female pelvic medicine, see I was right, and reconstructive surgery. He completed his fellowship at the Northern California Continence Clinic in Urogynecology, Female Urology, and Voiding Dysfunction. Ever since his fellowship in Voiding Dysfunction, he had an interest in neurogenic bladder. He has been involved in the clinical research that got Botox FDA approved for the bladder, and he continues to participate in studies and clinical research because he has this in mind of accepting a challenge, and his background and familiarity, whatever that word is, with neurogenic bladder and voiding dysfunction. He manages a lot of MS patients. His offices are in Aventura and Pembroke Pines, for anybody that needs to know. Let's welcome Dr. Samowitz.
Sorry, I didn't know what you needed. Okay, I'm going to be talking about how MS impacts the bladder, and what's probably significant is that a lot of this is also going to apply to those of you without MS, because a lot of these issues do affect, incontinence affects up to 46 million Americans. So we're talking about a very common problem, but particularly exacerbated in the MS patient. So I'm a urologist, and urologists are blessed with golden opportunities, with know-how to go with the flow, and we make the lives of our patients a wee bit better. Urologists are known to have a dry sense of humor, so da-dum-bump. So let's start off with what a normal bladder function should be like. If I use my hands a lot, I guess that'll show up on the video, because I'm Jewish, so it's going to be necessary. So the whole process of the bladder function is that the urine comes down from the kidneys through the ureters. There's two small, thin, spaghetti-sized tubes that carry the urine from the kidneys to the bladder. And most of the things that we are talking about are considered lower tract function. Lower urinary function is those involving the bladder. Upper tract is the kidneys. So we're mostly dealing with, initially, with the function of the bladder. And the bladder is a very complicated organ. My friends who are cardiologists, think the heart is such a big deal, but the bladder is actually much more complicated. I mean, just by talking about voiding and bladder function is probably getting some of you to want to use the bathroom. And it's a trigger, and there's a very strong mind-body connection between the bladder and the brain. And therefore, it's got all kinds of levels of superimposed function from upper levels to the bladder, and that's much more complicated than a heart that just simply pumps blood forward. So you can't stop your heart from beating, and you can't, initiate your heart the way we do the bladder. So when the urine gets down to the bladder has to expand, and it has to be able to hold the urine and store the urine without increasing pressure. And so it has to be elastic. And the bladder is a muscle, so therefore it has to relax and allow the urine to be stored in the bladder. And then on the other end, it has to be able to empty, and so it has to be able to push, and that's during the emptying phase. So there's basically, we try to look at the bladder as having two phases, the storage phase and the emptying phase. And it's a failure to storage or a failure to empty, and we kind of break it down in that way. The bladder muscle is also known as the detrusor muscle. So if you ever see that term detrusor, you'll know what that means. And then to make things more complicated, we have this sphincter, this valve, that basically is closed all the time, except when you want to urinate and the valve relaxes. So you have this valve that is tonically closed almost all the time, except for those few moments when you're actually voiding and it's relaxing. And all this has to be coordinated between the bladder and the sphincter and the pelvic floor and the brain, and everything has to be working together. And the problem with MS, of course, is that these interactions, these coordinations are interrupted by the demyelination in the plaques. So what are the most common symptoms of MS related to the bladder? Do you get up more than 2 times at night to urinate? Generally speaking, anybody that gets up more than 2 times, 2 being the upper limit, has something called nocturia, and that means 3 or more times per night. And the reason why that's significant is that if you're getting up too much at night, you're not getting the proper rest you need, that you're not getting the REM and the deep sleep that you need. So if you're getting up more than 3 times, your sleep pattern is getting interrupted. Do you urinate more frequently than you used to? Do you ever have to rush to the toilet to avoid having an accident? Do you leak urine or have accidents? And that could be, particularly on the way to the bathroom, or if you're just sitting there quietly and not moving, or if you're doing some activity, coughing, sneezing, laughing, lifting, straining, any kind of movement that creates abdominal pressure. So if you answered yes to any of these, you should be discussing this with your health professional. So there is the frequency and urgency of urination, where you have this urge to go, and the bladder sending a signal to your brain, I gotta go. And that's the sensory part of the bladder. And it'll sometimes send a false signal to your brain that you feel like you have to go. Then when you do try to go, there could be hesitancy. Hesitancy is where you're standing there or you're sitting there and nothing happens. And you feel like you got to go, you feel you're full, and you're not able to get it out. Frequent nighttime urination, as we talked about, is nocturia, more than 2 times per night. Incontinence is the leakage of urine. When urine is not being stored voluntarily, and it'll come out, and you are having incontinence. The inability to empty the bladder completely, that's considered retention. That's a problem with the emptying phase of the bladder, and that the bladder is not able to completely empty. It doesn't have to be completely. Usually we use the cutoff of about 60 or 100 milliliters. It varies a great deal. But the reason why that's also important is that if you leave urine behind in the bladder, that's a setup for infection. It could be a setup for bladder stones. It could even be bad enough that if the urine backs all the way up to the kidneys, you can get kidney failure. And the patients, when you have a bladder that doesn't empty completely, it can affect your urinary frequency and urgency, because if you would just assume the bladder holds approximately about 400 milliliters, or about, I guess that's about 12 ounces or so, if that's what the bladder holds and you leave behind 6 ounces, then you're only able to use the other 6 ounces. You're only able to use half your bladder. So you're running back and forth to the bathroom frequently because when you walk out of the bathroom, you're already half full. So how does MS affect the voiding? Well, the bladder dysfunction occurs up to 80% of patients with MS, so it's a pretty common problem. And again, it's because these lesions that are in the brain and in the spinal cord affect the bladder and the external sphincter, the urinary sphincter, and their coordination. And the whole process of voiding is complicated because there's places in the brain that are responsible for voiding, and there's a sacral micturition center. There's a place in our spinal cord that also helps with voiding. And so patients that are MS or spinal cord injured patients have particular problems with voiding. And patients that have stroke or other brain injury will also have a different type of voiding. So because MS affects the whole central nervous system and it gets complicated, every MS patient is different in that respect. So types of voiding disorders in MS. So we have first, the most common is overactive bladder. I'm sure many of you are familiar with this. You've seen the commercials on television. Again, this is one of the most common chronic problems to affect people, 46 million Americans at least. Most of the time it's women, but it also affects men, and it's where the patient has a urge to go more frequently than, let's say, 7 times a day, or as we said, nocturia, more than 2 times per night. So those are sort of the cutoffs. You should be able to sustain your bladder or hold your urine for at least 2-3 hours. That's sort of the minimum, and that allows you to have a normal function, that you can sit through a movie, you could go out socially, you can go for a long drive. So we aim to have about 2 to 3 hours at a minimum for storage. And that's a problem of overactive bladder. Underactive bladder or hypotonic bladder is one that doesn't empty completely or adequately, and urine is retained. And that's actually a much tougher problem because the bladder muscle it gets weak and it doesn't function, and we don't have a way of really replacing that. Many MS patients suffer from dyssynergia. Now, dyssynergia is a really important part of MS because that is where you get the lack of coordination between the bladder and the pelvic floor and the sphincter muscle, where the two have to talk to each other. So during the storage phase, the bladder has to relax and fill and store the urine, and the pelvic floor and external sphincter have to contract and hold the urine in. During the emptying phase, the bladder has to contract, squeeze the urine out, and the pelvic floor has to relax to let the urine flow, and the external sphincter has to open up to let the urine flow out. It's when these two don't talk to each other, the lack of communication, the coordination, that we get something called dyssynergia. And I'll talk a little bit more about that later. Compliance of the bladder is the elasticity. So a bladder that is chronically squeezing all the time is going to lose some of its elasticity. So therefore, it's not going to expand when it needs to store urine, and it's not going to be able to contract well either because it gets kind of stiff and scarred and rigid. And it's not a muscle that is elastic anymore. It becomes sort of a rigid ball. An incompetent sphincter is the valve that is supposed to keep you dry. The sphincter becomes weak, and it can become weak for various reasons. It can become weak from neurological reasons, but it can also become somewhat weak from mechanical reasons, particularly in females. What happens is with childbirth and aging and so on, the valve that keeps them dry loses its support. And as the valve drops down and with increased abdominal pressure, coughing, sneezing, laughing, lifting, straining, bearing down, anything that causes that pressure to push that valve down, it lets go. The valve simply opens up and the urine falls out. It'll also happen in men who have had perhaps a radical prostatectomy. They've had surgery and they've damaged their sphincter. But it can also happen in MS patients that neurologically it's not functioning well. So we break down urinary incontinence, that leakage of urine, into multiple types. So the urge incontinence is where the bladder starts to squeeze without your permission. You may be on your way to the bathroom, you just can't get there fast enough. And the bladder's starting to contract and create pressure, overwhelming the sphincter, and it pushes urine out. That's the most common. Stress incontinence is where I just mentioned the mechanical process of the sphincter, the valve, is supposed to keep you dry, it drops down. And as it drops down, it opens up. And it's not the stress of a bad day, it's a mechanical stress. It's really badly named. I wish they would change that. But stress incontinence is due to a mechanical stress. And it's with coughing, sneezing, laughing, lifting, straining, bearing down, jumping, running, anything that creates abdominal pressure and moves that valve down. Mixed incontinence is a combination of the two that we just mentioned, urge and the stress. And of course, you know, that's more complicated to treat and diagnose and treat, but it's also much more common because they make it complicated for us. Overflow incontinence is where the bladder gets to a maximum capacity and they just overflows. It just overextends and overdistends, and the bladder leaks urine because it can't hold anymore. And that's because the patient's in retention. Functional incontinence occurs when other disabilities make it excessively difficult to reach the toilet or get undressed. Those patients that have very advanced MS who are wheelchair bound and can't get to a commode unless they have major assistance, then we have a difficulty with managing their incontinence because they're sitting in a chair all day. Healthy bladder function is essential for long-term kidney health, prevention of infection, personal independence, self-confidence, and quality of life. Worsening of other MS symptoms such as weakness and spasticity. Obviously, if you're affecting other organs and other problems come up, either infection or inflammation, skin changes, this will affect other parts of your overall health. Repeated bladder or urinary tract infections, kidney stones are a problem. Challenges with work, home, and social activities, loss of independence, self-esteem, and self-confidence, where the patient becomes afraid to do anything socially. They become isolated because they're concerned that they're going to have to be near a bathroom all the time, or that they're going to embarrass themselves. It's a big problem. We sometimes refer to the incontinence issues as closet disease because it's hidden away. If a person living with MS suspects bladder dysfunction, what should they do? Well, early medical evaluation is the key, and we try to determine the cause of the bladder symptoms and choose the appropriate treatment. The sooner that we start to manage the problem, the better, because we can avoid some of the long-term problems and complications. As I mentioned, the bladder becoming stiff and rigid, we can try to keep that muscle healthy and avoid infections and so on, and avoid damage to the kidneys as well. At their most serious, untreated urinary problems can lead to infections in the blood, urosepsis, renal failure, and skin breakdown, 3 factors that can shorten the life of someone with MS. So although it seems somewhat trivial to talk about urination, it really can have a significant impact on the patient's life and health. So let's talk about how we work up a patient with these problems. So history and physical exam, and that's obvious. We are going to ask a lot of questions about other medications that you have, maybe other surgeries you've had, other problems that you have that will impact urinary incontinence. The physical exam will try to get you to actually leak in front of us and see if you do have stress incontinence. Urodynamics, I have a slide that's specific to that. I'll get to that in a moment. Cystoscopy is where we look inside the bladder with a flexible little scope. It has a light at the end, fiber optic. It takes me about 60 seconds. It's cold, it's wet, it's uncomfortable. In the female, it doesn't hurt. In the male, I'm not going to lie to anyone, it hurts for about 1 second. And that 1 second is when I'm going past their sphincter muscle to get into their bladder. But it's an invaluable tool to see what's going on with the patient. Anatomic imaging. So typically that's the upper tract studies because we're looking directly into the bladder, so we don't need usually a lot of imaging of the bladder. But the anatomic imaging of the kidneys is usually done with renal ultrasound or even better yet, a CAT scan. Functional imaging is where it's not just the anatomy that we're interested in, we're interested in the function. So if we want to know what the kidney function is like, or if there's any evidence of obstruction, we would use a nuclear medicine test called a renal scan with Lasix washout. And that's where the patient is given, it's sort of a reverse x-ray. The patient is given a little bit of a radioactive tracer, IV, that the kidneys then pump out, and they hold a big camera, almost like a Geiger counter, that monitors how rapidly the tracer is being flushed out of the kidneys. And then towards the end, they give the patient a little bit of a diuretic, Lasix, furosemide. And what that does is it forces a flush of urine through the system so they can see if there's if they can see if there's any kind of obstruction. If there's a blockage of any type, it'll show up more clearly if you give them a little bit of a flush. With the diuretic, Lasix. A BVI is a type of an ultrasound that we do in our office when the patient is just coming in for often a routine visit, where we'll check how much urine is left behind. When the patient comes out of the bathroom, I'll often ask my nurse, do a BVI, and it technically is an ultrasound, but you don't really see what's going on in the bladder. All it really measures is the volume of urine in the bladder. And so, the patient goes to the bathroom, they give me a urine sample, we check it for infection, we check it for blood, we check it for sugar, we'll check it for a lot of other things with a dipstick, and then we'll have them lie down, we run this quick ultrasound with some jelly on their belly, and we see what's left behind. And hopefully the patient's emptying adequately. So the urodynamics test is really one of the real important tools in the MS patient. Because the MS patient is particularly complicated for their voiding dysfunction, the urodynamics test helps us to identify where some of these issues are. Is it bladder? Is it sphincter, et cetera? Is it underactive or overactive? So what the study involves is where the patient has a small little catheter placed inside the bladder. It's about the size of a spaghetti. And that catheter has a pressure monitor in it. It also has another channel that allows water to be instilled into the bladder. So they get hooked up to the computer, essentially, with this catheter that is filling their bladder with water and measuring the pressures in the bladder. They also put a probe in the rectum. It's a little wire that goes in the rectum to measure pressures in the abdomen. By putting it inside the rectum, we can measure abdominal pressure, because we can't really measure the bladder pressure directly because the bladder's inside the abdomen, and there's additional pressure that's added to the bladder from the abdominal muscles from outside. So we put a probe in the rectum to measure abdominal pressure. We put a probe in the bladder to measure the bladder pressure. But the real thing we're interested in is something called detrusor pressure. And again, that's the bladder muscle. So what the computer does is it subtracts the bladder pressure, it subtracts the abdominal pressure from the bladder pressure, and what's left is the pressure that's generated by the bladder muscle itself, the detrusor. We also put some EKG pads, some little EMG pads by the anal sphincter. And as the patient is being filled and as they're emptying, we're measuring the electrical activity of the pelvic floor muscles and to see if they should be tightening during the filling phase, as I mentioned, and they should be relaxing during the emptying phase. And if they're not doing that, that's a sign of dyssynergia. The patient will sit on a commode and they get these all hooked up. It seems like a science experiment. And it's not very comfortable. It takes about 45 minutes, but it's really not bad. It's not painful, and again, it gives us valuable information. The most basic urodynamic test that we do is something called a uroflow, and that's where the patient simply pees pees into a commode that has a flow meter attached to it, and we get a printout of the flow, and it allows us to see the pattern of flow is very telling. We see the peak flow. We see their pattern of flow. Is it a zigzag curve? Is it a nice smooth curve? We like to look for something called a bread loaf curve, where there's a rapid rise, it plateaus, a rapid decline, patient's finished, leaves the bathroom. And then we, of course, after that, we'll check their post-void residual with that BVI ultrasound I mentioned. So let's suppose the typical MS patient is starting to have some issues. It's not horrible yet, but they've already been checked out to make sure there's nothing serious going on. What are some of the simple things that we can try? Well, dietary modifications. Sometimes the MS patients are prone towards urinary tract infection, and I have a whole regimen that I do with my patients that get frequent UTIs. But the simplest thing to do is to take extra vitamin C and cranberry pills. Vitamin C, I'm talking about 1,000 milligrams twice a day. It's excessive. You want the cheapest vitamin C you can find. The good vitamin C is designed to stay in your body. We want this to end up in the urine. Vitamin C is a water-soluble vitamin. It gets dumped in the urine. It makes the urine acidic. It's ascorbic acid. That's the other name for vitamin C. So therefore, it makes the urine acidic. The bacteria don't like acid urine. They don't grow well. The other thing is cranberry pills. Cranberry juice would work if there was any cranberry in it, but there's very little cranberry in cranberry juice. It's mostly sugar water. So don't waste your time with cranberry juice. It may taste good if you like it, great. But you really got to take cranberry pills, either tablets or the capsules. They take the cranberry, they take the fruit. This is how simple it is. They take the fruit, they freeze dry it, they crush it into a powder, and they put it in a capsule or tablet. It doesn't have to be anything fancy. I don't have any particular brands that I can endorse, but again, I usually tell the patients go for the least expensive as long as it's got cranberry in it. Avoiding dehydration, you already heard the talk about that, because dehydration affects you in so many other ways, and it actually will affect your voiding as well. Concentrated urine is more irritating to the bladder. The bladder has a lot of sensory nerves to it. So anything that irritates the bladder, it's a stupid organ. It only knows two things, full and empty. So if the urine is too concentrated and irritating, you need to empty your bladder. You need to rehydrate to make the urine less irritating, less concentrated. For patients that are getting up too much at night, sometimes the easiest thing is don't drink a lot of fluid after dinner. Just reduce your fluid at night. You'll make up for it during the day when it's easier for you to get to the bathroom. And then there's a number of things that you can do, like Kegel exercises. You heard a little bit about that a few minutes ago. There are Kegel exercises are what we do when we try to stop the urine. It's not easy to do. These are non-intuitive muscles. You got to do these exercises a lot. That's the problem. People forget. It's a nuisance to have to remember to do these exercises throughout the day, but they are effective. And then we sometimes will send patients for physical therapy, pelvic rehabilitation. There are specialists that work in the pelvis, physical therapists who are specialized, and they're very helpful. We have in our practice somebody who does bladder training and pelvic therapy, and that's a little less involved than the physical therapy and pelvic rehab, but what they do is they'll put the EKG pads I mentioned on your bottom, and they'll teach you which muscles you have to exercise and work with you and show you over time that you're getting stronger, like a personal trainer for your pelvic floor. Because the truth is 50% of patients don't do these exercises correctly. And it's hard to identify these muscles. It's not your abdominal muscles, it's not your thigh muscles, it's not your buttock muscles, it's the muscles in between. There are other things that you can do, such as planned voiding, making sure you're voiding about every 2 hours or so. If it's a problem, you go by the clock. Some patients, the sensory part of their bladder is not functioning. They don't feel when they have to go. And so rather than relying on that urge, and by the time they get that urge, they only got 5 minutes and they aren't in a bathroom, they're in trouble. Instead of waiting for their bladder to tell them that they have to go, they do it by the clock, and they do sort of defensive voiding. Double voiding, it can be used for patients that are not emptying their bladder well. They're leaving urine behind. So if they have to urinate, they go, they stand up, relax, take a few breaths, see if they're okay, and then sit down again and try to get some more out. The Credé maneuver is where the patient will use their hands and kind of push on their bladder and use their hands to create more pressure. These things should only be done with the advice of a urologist, because you could do damage if you aren't able to. If you have an obstruction and you're trying to Credé and it's not really appropriate for you, then you're just increasing bladder pressure and doing some more harm to your bladder. But for a patient that has a hypotonic, underactive bladder, that's sort of a floppy sac, instead of the bladder being a muscle, it's just a floppy sac, that will help that patient to empty more completely. So just quickly, drinking enough so that the urine stays a light yellow color is a good indicator if you're well hydrated. Certain foods are irritants to the bladder. Caffeine and alcohol are the classic ones. And then restricting fluid before bedtime can help you not get up so much. There are many different ways of trying to catch the urine and absorbent pads and so on. Some men can use what is known as a condom catheter, which is an external catheter that collects the urine to a bag rather than having to wear a pad. They have that option sometimes. Pelvic floor exercises, we've talked a little bit about that already, and timed voiding. So that's the first step, is try to avoid medications, but sometimes we have to go to medication. Quite often we do. And most of these medicines are designed to help the bladder store better. So there have been multiple generations. There's dozens of medicines out there that are for this problem. And I like to break it down into different generations because there's so many of them out there. So the first generation is oxybutynin or ditropan. It's about 40 years old, I guess. It was the first bladder medicine that came out specifically to control the bladder. And we still use it. It's a good medicine. All of these medicines, or most of these medicines, will have the side effects of dry mouth and constipation. They're known as anticholinergic or antimuscarinic. And unfortunately, a lot of the other medicines that MS patients take have the same side effects, so this can make it even a little bit worse. Sometimes they don't even notice it because they're so bad already anyway. But anyway, oxybutynin has been around a long time. It's generic. It's inexpensive. The problem is that in its immediate release form, it only lasts about maybe 6 to 8 hours. They've come out with extended release form, which is a bit better, and they also have it as a gel or even a patch. The patches are available, I think, without a prescription. They're very expensive, and they leave a kind of a rash, so I'm not a big fan of the patch. The second generation of these medicines is Detrol and Sanctura. These are a little less of the side effects of dry mouth constipation. They've also been around about 25 years, and they have less of, they're also generic usually and very affordable. And they've been made to last 24 hours. The third generation, Vesicare, Toviaz, and Enablex, these are not generic yet. They tend to be a little bit pricier. They still have some of those side effects. And we don't use them too much, primarily because they're still fairly expensive. The newest one is a different different class of medication. It's known as Mirbitric or Mirabegron. And it is not an anticholinergic directly. It is a beta-adrenergic. And from your purposes, it doesn't matter, except it's interesting that it's a totally different class of medicine, and it works very well for the bladder. It takes longer to take an effect, but it has far less of the dry mouth and constipation, and they do a lot of advertising. That's the one that has the woman who's trying to, I think, teach a music class, and the little cartoon bladders trying to drag her into the bathroom. It's very clever. And it's showing that the bladder has like a mind of its own.
Anyway, Myrbetriq is a good medicine. It tends to be pricey, but it's often covered by insurance. It has one small side effect in that it can raise your blood pressure a tiny bit. We haven't had many patients that have had to stop it because of blood pressure, but it can raise your blood pressure. So if you have volatile blood pressure problems, this may not be the best. There are many other medicines out there for the storage of urine. Imipramine is one that we traditionally used to use in children that wet their beds. It also has the benefit of tightening the sphincter. It'll chemically tighten the sphincter muscle. Levsin is good to be used in special circumstances because you could pop it under the tongue. So if you put it under your tongue, it'll work in about 90 seconds. And then it lasts about 2 to 3 hours. So it's good to keep when you're traveling and you've got, let's say, the window seat in the plane and there's nothing you can do. There are other ones out there, Urabel, Urogesic Blue. These are combination medicines. Typically, the most important parts of it are the methylene blue, the hyoscyamine, the methenamine. It's a shotgun approach to the bladder problem. And it's got a little bit of everything in these same pills. They tend to be a little bit expensive. There are coupons that I pass out, and they change the color of your urine. They make it a greenish blue, so you know when somebody's on Urabel or Urogesic Blue by the color of the urine. Pyridium, a lot of women are familiar with because they take it in the form of azo, which is over-the-counter Pyridium, and it'll numb their bladder. I've done a lot of work on Botox. Botox is a great medication. It does have to be injected into the bladder. It is a procedure that will work for about 6 months, and it's for the severely overactive bladder, the intractable overactive bladder, and it's a great medication. Neuromodulation. If I'm speaking a little fast, it's because I know I'm running out of time, so I apologize. Neuromodulation is where we use electrical stimulation for the nerves, and the one that's been around for about 20 some odd years that I've done is Interstim. Interstim is sort of a pacemaker for the bladder. It gets implanted. The problem with it is that it doesn't work that great in MS patients. I gotta tell you, I've been very disappointed. I think it has something to do with the nerves being somewhat weak from the demyelination. It works well initially, and then after a couple months, the patient is right back to where they were. So I've been disappointed with Interstim in the MS group. You also can't have an MRI, and that's a problem for a lot of MS patients because it is like a pacemaker. It's metal. You can't have MRI. The other one type of neuromodulation is posterior tibial nerve. That's where you get a little acupuncture needle in your ankle. You get electrical stimulation once a week for 12 weeks. It takes about 30 minutes per session. And over time, it sort of retrains the bladder. It's got an 80% success rate. Again, I haven't used it a lot in MS patients because I don't think it'll be as effective. But the other problem is insurance coverage, because after the 12 weeks, you're supposed to do it once a month, and then after that, you're supposed to do it once every 3 months and try to wean down. But it sort of retrains the bladder to some degree. Patients that have a difficulty emptying their bladder, the underactive bladder, the retention patient, much more difficult to manage. And it's unfortunately a common problem in MS patients. We try to use the alpha blockers, the ones that we use to relax the prostate for men that have to urinate better. And we use this in women too. It's not unusual for a female patient to be on a medication that is normally indicated for men with enlarged prostate. Urocholine is supposed to make the bladder squeeze harder. Unfortunately, it doesn't get absorbed very well. So it would work if it could get absorbed from the GI tract. It tends to give the patient more of a bowel contraction. Intermittent self-catheterization, I have a slide on that, but that's where the patient learns how to drain their bladder with a small catheter, and then does that about up to 4 times a day typically, drains their bladder, and throws away the catheter. A chronic indwelling catheter is for the patient that is not able to do intermittent catheterization, and that's an indwelling Foley catheter, either a urethral catheter or in some cases suprapubic catheter, where the tube comes out below the belly button, and that tube has to be changed every month. But it does help people to be continent and dry and avoid damage to their kidneys. And Interstim we mentioned. So intermittent self-catheterization is quite simple. I put up this slide just to show patients that it's not as scary as it sounds, where the patient will drain their bladder with a small disposable catheter. The insurance companies are very happy to cover this. This is always well covered by companies, and they can get these catheters shipped to them, as many as they need, and they're disposable, they're small. They have ones that come that are sort of retractable. They look like a lipstick, and they're already lubricated, and they're very easy to handle and learn how to do this. So questions to ask yourself: since you first got diagnosed with MS, am I finding it more difficult to start urinating when I get to the toilet? Do I feel as though my bladder isn't completely empty when I finished urinating? Do I experience frequent or recurrent urinary tract infections? Am I using pads or any other strategies to protect my clothing from urinary leakage? Am I limiting the amount of fluids I drink because I worry about having to urinate frequently? Am I planning my daily activities around my bladder symptoms? Do my bladder symptoms keep me from doing what I enjoy? If I had to spend the rest of my life with my bladder behaving the way it is, would I be unhappy? Okay, and we'll be answering some questions after the next talk. Thank you very much.
Thank you. Thank you, Dr. Samowitz. Dr. Kantor is the Neurology Residency Program Director of Florida Atlantic University's Charles E. Schmidt College of Medicine in Boca Raton, Florida. Dr. Kantor is the President Emeritus of the Florida Society of Neurology, founding President of the Medical Partnership for MS, and Chair of the Subcommittee on Concussion for the Sports Medicine Advisory Committee of the Florida High School Athletics Association. He's a past board member and chair of education of the Southern Florida Headache Society and past director of the University of Florida Comprehensive MS Center. As a subspecialist in multiple sclerosis, migraine, and concussion, Dr. Kantor is very involved in patient advocacy and is an active member of the multiple patient advocacy not-for-profits. He's also a proud member of MS Views and News Medical Advisory Board. Yay!
Well, thank you so much for having me. How's everyone feeling today? Okay, good. Well, you've heard from Jeff Siegel and you've heard from a urologist. Now you're going to hear from a neurologist. And the idea is, what can we do to make your MS care better? Another way of thinking about this is, what can we do to make you the most successful, MS, or most successful? What you see here in this image is a person who is the first person we think of in recorded Western history to have had multiple sclerosis. She was ice skating and she fell and she was weak for 6 months. Then she got better. Then she lost vision in one eye and it got better 3 months later. Because bad things happened, followed by good things, the Catholic Church decided that she was a saint. And she was named the patron saint of ice skating. And that's what we understand, that Saint Ludwina was actually probably the first person that we've ever recorded in history to have had multiple sclerosis. MS remains a clinical diagnosis. The most important thing that we can understand, not are these fancy MRIs, these fancy blood tests, all these other fancy tests. If we really listen to what Sir William Osler said in 1903, he said that the best teaching is that done by the patient himself. Now, it was 1903, so we'll forgive the latent chauvinism. He didn't say herself or themself, but he said the best teaching is that done by the patient himself. And we still think that's true today. And that's why we came up with this idea called MSTAR, or Multiple Sclerosis Team Approach Rule. It's a very simple idea. The idea is that the person with MS is at the center of their team. Everybody on the outside is important, but nobody is as important as the person with MS in the middle. So on the one side, you see the doctor, the nurse, you see the nurse practitioner, physician assistant, the physical therapist, occupational therapist, speech therapist, nurses, all of the healthcare providers. We're not as important as the the center of that star, the person with MS. On the other side, you have the other people who are really important. You have the friends and family. You have the significant other. You have the care partner. They are very important. More important than the doctors, but still not as important as the person with MS. You have the job, and that either means retaining your job with the amazing American with Disabilities Act that we're blessed to have here in the United States, or when it's time to apply for disability, applying for Social Security disability. And then if we think about the MS community, the MS community impresses me every day. The MS community means big groups, it means small groups, it means large not-for-profits, small not-for-profits. It means people making jewelry to try to help support what we're trying to do here in multiple sclerosis. It means mega nonprofits that are trying to bring in big research dollars to try to find the cure for multiple sclerosis. All of that together is the MS community. And I think there's nothing that better exemplifies the MS community than MS Views the News. So everyone's needs in MS are different. If you look at the internet and you type in almost anything, you're going to find multiple sclerosis. And that's because MS affects the central nervous system. And everyone has their own unique needs, which means that you have to be selfish when you go into the office visit. You have to talk about yourself. When you're in settings such as this one, ask general questions. But when you're in your doctor's office, ask pointed questions about your care. Understanding that your care is different than her care or his care or their care. It's your care. Build your team. Your team is going to be different than other people's teams. Tailor your team to your needs. Have open lines of communication. It's not acceptable in today's age for you to have to say, well, my primary care and my neurologist don't talk. Well, that's a problem. They should. They're your team. How can you have a functioning team if they don't communicate? Make trades when needed. If somebody on the team is underperforming, make that trade. Find somebody else who can be part of your team. And don't forget that the ugly, ugly red Pac-Man is jargon. There's a terrible word that means fancy words, and it's a fancy word. It's jargon. It's a fancy word that means fancy words. There's no space for jargon in the doctor's office. Not coming from the doctor and not coming from you. Your doctor should be explaining things to you in easily understandable language. But also don't go to your doctor and try to make your diagnosis and try to use fancy words. You're not impressing your doctor, you're just confusing them. When you say, I have neuropathy, I get confused. Because neuropathy is not caused by multiple sclerosis. Neuropathy is most common. Polyneuropathy is caused by diabetes. And then I'm thinking about diabetes, and then 10 minutes later, I'm like, oh, wait, you don't have diabetes. So why are we talking about diabetes? Well, if you hadn't used the word neuropathy, that never would have happened. So don't let your doctors use jargon, and don't you use jargon either. Just to make sure we're all on the same page. What is MS? Well, MS we think of as a lifetime autoimmune diagnosis. And you'll notice that today I'll use a lot of words like think. And the reason is that every 20 years, half of what we know right now in medicine is found out not just to be false, but to be 180 degrees false. But we don't know right now what that's going to be in 20 years. So our best understanding right now is that MS is a lifetime diagnosis. It's not chronic, it's not lifelong. That makes life sound long and arduous. It's lifetime. It's kind of like the cable station with a similar name. When you turn off the TV, it's still going on in the background. When you don't pay attention to your MS, it's still going on in the background. Even when you're not watching TV, you still have to pay your cable bills. Even when your MS isn't bothering you, you still have to take disease-modifying therapies. You still have to make sure that you are protecting yourself for the future. We think of MS as affecting the central nervous system. We're learning more about how sometimes the peripheral nervous system can be involved, but we really think of MS as affecting the central nervous system. We think of the spinal cord affected most commonly, then the optic nerves, then the brainstem. We think of it both loss of myelin, that white matter covering around the nerves, as well as the actual nerves themselves. We think both those things happen. And we think it happens in somebody who has some sort of genetic predisposition. Not an MS gene, but a collection of lots of genes that put you at greater risk. and that person then has some sort of environmental trigger. If we understood the genetics or the environment, we would be traveling to Scandinavia to win a Nobel Prize. When Michael J. Fox, who's amazing, he's America's sweetheart, he wasn't talking about MS. He was talking about a very unrelated diagnosis called Parkinson's disease. But he said that in Parkinson's disease, your genetics loads the gun and your environment pulls the trigger. That same thing is true for multiple sclerosis. So if you look at a nerve, we see this white matter covering on the outside. We call that white matter covering myelin. I love that I can ask this. I cannot go to a group of people who have migraine and ask them questions about neuroanatomy. But we have that myelin, and what happens in MS is for some reason your body starts to attack that myelin. And what happens is you have immune cells that are in your bloodstream, and then they get activated, these T cells and B cells, and they cross through the blood-brain barrier. Then what's going to happen is they're going to launch an attack on your myelin as well as on your nerves themselves. And then what that's going to do is that's going to cause problems with your signaling. It's going to cause the problems of why you have that weakness, why you have that spasticity, that muscle tightness, why you have that sensory changes, why your vision isn't as good in one eye as it is in another. It's because of what's happened in multiple sclerosis. I expect everyone to remember this graph by the end of today. But this is constantly changing. As soon as we get one of these graphs up there, we change our mind about what is going on in terms of the immunology or the neuroimmunology of multiple sclerosis. We're learning more every single day. But what do we know? Well, we used to talk about 4 subtypes of MS. Now we talk about 3 subtypes: relapsing remitting MS, secondary progressive MS, primary progressive MS. Most people, 85% of people, are starting out where they have attacks that come and go. We call that relapsing remitting MS. But then what happens is sometimes some people go on to, even in between the attacks, they're still getting worse. Or they're not having attacks anymore and they're just getting worse. We call that secondary progressive MS. But 15% of people say, what are you talking about? I've never gotten better. Things are just getting consistently worse. We call that type of MS primary progressive multiple sclerosis. And so when you think about it that way, when you think about that terminology, it explains why often we'll focus on that attack. But I don't believe that that's the most important thing to most people with MS. I think oftentimes people with MS care about how the most of their life goes on. They care about what happens in between the attacks, what happens day to day as well. So that's why we came up with this concept of the 3 Musketeers. There's an amazing support group in Deltona, Florida, outside of Orlando. They let me use their name, the Musketeers. I do not know if Disney let them use the name Musketeers. But the idea is that these 3 swords of treatment, disease-modifying therapy, symptomatic management, symptomatic treatment, and then relapse treatment or acute exacerbation treatment in the middle. But notice I didn't say symptomatic medication. The reason I didn't say medication is because it's not only medications. In fact, very few medications have in their FDA label an approval that says multiple sclerosis for a various symptom. We do things like Tai Chi, yoga, breathing exercises, mindful meditation. Yes, we do use medications, but those are generally what we consider off-label. So let's go look through this. If we look at the FDA-approved disease-modifying therapies, in 2002, how many did we have? In 2002, we had, in 2002, in 1992, how many did we have? We had 0 in 1992. Now in 2019, we have 14 separate branded products, 2 unbranded generics, and 1 branded generic. In the last week, we've seen 2 new medications receive FDA approval. This is an amazing leap forwards that we have. Another way of looking at these medications is to also look at them as intersecting spheres. How do you take them? Are they self-injectables? Are they intravenous into the vein? Are they oral medications? And that's another way of looking at it. Your doctor should go through with you on these medications and talk to you about the advantages and disadvantages of the medications for you, not for society overall, but what are the advantages and disadvantages for you and for your care. If we look at what's going on in research, as you can see, most of this is green. And the reason is most things that get all the way to the full human trials called phase 3 actually get into development. There's one medication that we stopped after phase 3, and there's another medication that got approval and then was taken off the market. But we even had a medication that didn't make it and now has made it. So we are doing really well in terms of bringing new treatment options for more people with MS. Does that mean that we don't have more places to go? Absolutely not. Does that mean that we should stop and rest and not think about progressive MS? Absolutely not. Does that mean that we should stop thinking about remyelination, about forming new myelin, and think about ways of protecting the nerves? Absolutely not. We still need to do all of that. But we've come a long way in the treatment of relapsing forms of MS. And the Food and Drug Administration took a historic stance just over 10 days ago, where they finally, for the first time, defined relapsing forms of MS. And all those patients out there with secondary progressive MS, and they still had activity, and their doctors were telling them, well, there's nothing for you, those doctors were wrong. The Food and Drug Administration made it abundantly clear. Relapsing forms of MS means clinically isolated syndrome, it means relapsing remitting MS, and it means active secondary progressive multiple sclerosis. And that's why the Medical Partnership for MS released a press release regarding this and wrote a thank you letter to Dr. Billy Dunn, who's the head of neurology products at the FDA CDER. They handle the drugs, not the biologics. These are proactive medications. These are medicines that are not designed to help symptoms day to day. They do sometimes help that, but that's not what they're approved for. And that's not what they were studied for. What they're trying to do is give you insurance for the future. They're trying to be prophylaxis to make sure that you don't have future problems. We're trying to prevent relapses. We're even trying to prevent accumulation of physical and cognitive disability. Unfortunately, no diet has yet been shown to do this. Unfortunately, as of today, no vitamin or supplement has been able to do this either. I want to caution everyone about stem cells. It is very attractive to hear the siren call of stem cells and think that it's right for you. You could go on a nice trip to the Caribbean and spend $50,000 and have something that you have no idea what it is injected into your body. Many people will not drink the water in Mexico, but they will go to Mexico for unproven medications. And that makes absolutely no sense to me. We are getting there, though. We're starting to do the research. Most of the research, however, has to do with stem cells that are making new blood cells. So they're making new immune cells, and they're resetting the immune system. We have some medications that do that exactly the same way. And then other research is actually looking at stem cells that can have to do with neurons and have to do with the myelin, but that's much less research that's going on. It's unclear if for somebody with secondary progressive MS or somebody with primary progressive MS, if it's actually going to help them to have these stem cells that are the immune cells, stem cells, and whether all they're doing is taking on the risk without necessarily having the benefit. And there's studies starting out in New York, but what they're going to have to do is they're going to have to actually surgically place those stem cells on the spinal cord. And we're going to have to surgically place them within the brain. And then the question becomes, what about the spinal cord itself? Shouldn't we be doing research that has to do with the spinal cord because that is so affected in multiple sclerosis and so affected in progressive multiple sclerosis? So how do disease-modifying therapies work? Well, we don't fully understand how all the medications work because we don't understand MS fully. But we think we understand some things. We think some of them, what they do is they change your immune response, they immunomodulate. Other ones, what's going to happen is that they're going to keep those immune cells from attacking you. If they can't get into your central nervous system, they can't attack you. Other ones, we're going to try to push down those white blood cells. If there's less of them, then they can't attack you as much as they could before. And then other medications like stem cells are going to try to reset or reboot the immune system as well. What do we know about efficacy, about how strong these medications are? Well, compared to placebo, to nothing, we have a lot of studies. Compared to other medications, we have much fewer studies. Most of our medications were compared to taking nothing. That's becoming harder and harder to justify nowadays when we have so many medications and so many treatments. I talked about the other parts of the triple threat. Well, we also need to talk about what happens during an attack, during a relapse. What is an MS relapse? Well, other terms are exacerbation, and in fact, we used to use the word exacerbation, not exasperation. But that's actually the reason why we started talking about relapses. Neurologists were exasperated by patients calling them exasperations, so we just changed the word on you. Other people call them flares or attacks. And the idea is that it's a new or worsening symptom referable to the central nervous system that's lasting for longer than 24 hours, and that you were basically stable for the 30 days prior to that. It's much easier when it's a new symptom. It's much harder when it's worsening of an older symptom. Sometimes it can be confusing not just to you, but also to your neurologist about whether you're having a new relapse or whether you're having a disability progression or whether it's nothing to do with MS or nothing to do with neurology at all. That is where your neurologist can help you. There are outside eyes and ears that have experience examining people like you, and they can help and try to figure out, is this a relapse or is this not a relapse? One of the big things we first do is make sure you're not having a pseudo-relapse. A pseudo-relapse is a fake relapse. It's not that you're faking, it's that your body temperature, for everybody you could increase the body temperature and we would all get heat stroke. For somebody with neurological dysfunction, with MS, with stroke, with other things, you don't have to raise the body temperature quite so high, and it will cause this short-circuiting that will happen. And it will bring out older symptoms. And once you cool down the body or once you treat the infection, then the symptoms go away. Stress can do that as well. Stress raises your body temperature. So if you go to Dr. Google, the most famous doctor in the world, and you type in almost anything, you're going to find MS relapses. And that's true that MS relapses can almost be anything that you can think of. There are some that are more common, like visual ones or walking ones, but other ones like fatigue or depression are not described as much, but they actually can be an MS relapse as well. So how do we treat them? Well, remember, we want to avoid them in the first place. So if you're having too many relapses, that means my job is to switch your disease-modifying therapy. But how do I get you out of that faster? Well, I use things like corticosteroids. We use things like IV methylprednisolone, also called Solumedrol. Sometimes we use an equivalent dose of oral steroids as well. We do not use those Medrol dose packs. That was shown to actually have a worse outcome than no treatment at all. And then there's another form of treatment that's also FDA approved. It's called intramuscular or subcutaneous adrenocorticotropic hormone, or ACTH. And then we have other ways that are not FDA approved, like using IVIG. It's using immunoglobulins that we're giving to you, or cleaning out your blood with something called plasmapheresis. Now remember, in the triple threat, we said not just what happens in disease-modifying therapy, not just what happens in acute exacerbation, but what about symptomatic management? And this is frankly where I think most of our time is spent in the office. Although we talk a lot about disease-modifying therapies, your day-to-day symptoms are a lot of why you're seeing a neurologist, and that's what your neurologist should be helping you with. So remember, I said that sometimes people are interested in what happens during the attack. This is what happens in between the attacks. And you can see that in different studies, we see that it goes first spinal cord, then it's going to go to other things like the optic nerves, and then it's going to go to things like the brainstem. Headache is even up there at 4%. I personally have an interest. I'm one of 484 people in the United States who are board certified in headache medicine. Very few of that 484 are actually also MS specialists. So that's my particular interest, as somebody who has migraine and multiple sclerosis. And I think what you can do is you can fix things. And sometimes the way to do that is to understand what is the issue. And so I think it's useful to describe to your neurologist, is it a visible symptom? Can somebody across the street see that you're not walking right? Well, that's a visible symptom. An invisible symptom would be something that people can't see, your problems with thinking. And a private symptom would be something it's not invisible, but it's something that people don't know because they're not in the bedroom with you. So they don't know that you have bladder problems. And that's a private symptom of multiple sclerosis. And if you look again at the same list, almost anything can be a symptom of MS. So I thought, it's a good idea to think about what are the different kinds of treatments that we use. Well, we use a multimodality. We use education. We use therapists. Yes, we do use medications. But I always tell people, you go to a surgeon for surgery. You go to an acupuncturist for acupuncture. Of course, you're going to go to a medical doctor, and one of the things we're going to offer are medicines, because we're expert in how to use medicines both on-label as well as off-label to try to help your unique situation. So why should everyone, not just people like me who are interested in migraine, why should everyone care about migraines? Well, everyone should care because this is the population. 47 to 99% of the population have ever had a headache. Everyone's had a headache. If you look, though, at people with migraine, we're talking about 13% of the population in the United States, as well as almost every country in the world has migraine. So you think about it, there's 40 million Americans with migraine. There's 400,000 to 1 million people with MS in the United States. Sometimes there's going to be overlap. If I describe to you a disease or a diagnosis where there's people who have a genetic predisposition, there's inflammatory soup on the meninges, there's white matter spots in a quarter of some series. Normal appearing white matter is not so normal. You might say I'm describing MS. I'm actually describing migraine. There's a lot of similarities that sometimes can happen, and I personally do feel that some forms of migraine are autoimmune and some are inflammatory forms. So out of 100 people, you're going to have 12 people who are going to have migraine. You're going to have another 2 people that are going to have chronic migraine. They're going to have migraine more than 15 days a month. They're going to be having headaches more than 15 days a month. If you ever want to know what a migraine is, just look at this picture of Marilyn Monroe. Look at her holding her side of her head. But then we're doctors, so we have to make things complicated. So what did we do? We made things complicated. Instead of just saying that migraine is going to be a recurring type of headache that can impact your functioning, instead of saying that, what we did is we created criteria. And oh boy, did we create criteria. And oh yeah, we created more criteria. And then we said, let's create some more criteria. That's what we do in medicine. We take things and we systematically divide them up and find language to make it as confusing as possible. Some of us, though, have figured out a better way. How do you make that diagnosis? Well, you can make that diagnosis pretty simply. So remember, most people with migraine are not going to have an aura. They're not going to have a warning sign. But people who do, it's going to be this castle fortification most commonly. There can be sensory auras. There can be other types of auras as well. That's the classical migraine. The common migraine has no warning sign. And there's phases of a migraine attack. There's a prodrome. You're feeling yucky beforehand. Then you might have a warning or you might not. You have the actual headache, and then you feel drained afterwards. And that's the postdrome of the headache. But you may be wondering, well, do I just have a sinus headache? Well, the myth is going to be busted. There's no such thing as a sinus headache. Neurologists don't believe in them, and the ENTs, the ear, nose, and throat doctors, don't believe in them. And the reason we don't believe in them is if you start to look at symptoms of migraine, most people with migraine have symptoms that are referable to the sinuses. They have sinus congestion. They have sinus pain. All those symptoms that you think are sinus pain and sinus related are actually migraine related. And then you might say, well, what happens with a stiff neck? I have a stiff neck. Doesn't that mean I have meningitis? What does all that mean? Well, it turns out that most people with migraine are going to have a stiff neck as well as part of their migraine. So a stiff neck alone is not an indicator that it's not a migraine. Migraine can really be disabling. I know that in the field of MS, we like to say that MS is the most common disabling neurological disease of the young that's atraumatic. I've got to tell you, that's not true. The most common disabling non-traumatic neurological disease is actually migraine. Migraine affects 40 million Americans. In almost every population, 3 to 5% have chronic daily headache. This is impactful. This stops people from working. They may try to go to work and they may be there but not actually be working well. We call that presenteeism. Then there's absenteeism, where they don't actually show up in work. Migraine can be very, very disabling. So there is this tool that we discussed. This tool is called ID Migraine, and what you try to do is pin the diagnosis. You take 2 of 3 of the following. So the PIN stands for photophobia, light bothering you. Impairment is impacting your life, and you have nausea with it. If those things are happening with your headache, you are probably describing a migraine, and it is worthwhile to go see a neurologist to have that diagnosis made. There's other types of headache. The most common type of headache is not a migraine, it's a tension type headache. But those aren't the headaches that people come to see neurologists or even doctors for. That's the one you take a leave and you take Tylenol and you don't tell anybody about. You just keep going on with your day. It's basically the non-migraine. It's almost the inverse of what happens in migraine. What you need to do is make your office visit your office visit. What you need to do is be prepared. Come to seminars such as this one. Write things down. Have your list of your medications. Have it not just written out, have it typed out. Listen, I know that doctors don't write nicely. When you go to Catholic school, they slap your hand if you write too messy. When you go to doctor school, they slap your hand if you write too neatly. I understand that, but I also understand that a lot of people with different diagnoses have not such good handwriting and not such good handwriting anymore. Also, you want to think, well, you're going to change your medications over time. Wouldn't it be easier to just edit it and then to reprint it out? Don't just keep it on your smart device. We cannot scan in a smart device. We can scan in a piece of paper. Also, if you're in a car accident for nothing to do with MS, how are they going to open up your locked iPhone? Instead, keep that piece of paper with your medicines, with your allergies, with your doctor's names, with your emergency contacts. Keep that opposite your identification. Keep that in your wallet or purse. What you're going to want to do is you're going to want to bring your actual MRI CDs or films to your neurologist. We don't want to just look at a report written by somebody who doesn't know you. We need to actually see what's going on. You want to tell the office your specialty pharmacy as well as your regular pharmacy. You also want to know your authorization anniversary date. They didn't teach you this in patient school. They didn't teach me this in medical school. But the truth is, to get anything nowadays, you have to get prior authorization. And that prior authorization might expire in a year, it might expire in 6 months, it might expire even less than that. But what happens is you go to the office, you don't tell us that's the issue, then you go home and suddenly you can't get the prescription. You think it's a refill issue. It's not. You've just wasted 10 days figuring out that it's not a refill issue, that it's actually a prior authorization issue. And so what you want to happen is you want your pharmacy to send in the refill request to your doctor. You want them to fax in the request for prior authorization. You want to know your date. You want to time your office visits to 1 to 2 months before your new authorization is needed. So the doctor can know you very well when they're filling out those forms and answering those questions. Know your date. And if we do all this, what I think we can do is take the idea of the multiple sclerosis team approach rule. And what we can do is take this idea where the person with MS is in the middle, and we can start to form networks where people with MS help other people. When we had that terrible hurricane that was headed right towards us just a year and a half ago, we saw the worst in people and we saw the best in people. My wife was filling up gas, and there was a guy honking at her and swearing, and he had a child in the back, and she had our child. And she walks in to go pay because you couldn't pay at the pump. And they said, oh, that guy, he's a school teacher. It brought out the worst in him. Armageddon is going to be worse than in the movies. But then I had people on Facebook and in social media with MS who had a need in Orlando or a need in Tallahassee. And other people went to their house and they lifted their items and they put them in the attic to try to avoid any kind of water damage that will happen. We see how natural disasters can actually show you both the best in people as well as the worst in people. And I believe strongly that this MS community is the best of people. And by working together, these individual M-stars, by working together as a community, by working with these principles of patient care, of education and research, I think we truly can create this interaction of these individual M-stars that will be the multiple sclerosis patient network. And I think MS Fusion News is a great example of where patients coming together can do amazing things. And those amazing things can have an impact not just here locally, but can have an impact across the country and across the globe as well. So good news is that in terms of research, when we were in the 1950s, we saw a couple articles about MS. And then it started seeing more. And then in 1993, we saw a first disease-modifying therapy. And now 75% of our journal called Neurology is filled with multiple sclerosis. We have an asymptotic increase. In just 1 week, we saw 2 new FDA approvals. That's amazing. That's unheard of in most of medicine. Forget about the rest of neurology. And so I think if we do these things together, then what we can do is take the multiple sclerosis team approach rule and we can turn it into the multiple sclerosis team approach reality. I'd like to thank you so much for your attention, and I'd be more than happy to take any questions that you might have.
I thought you were wrapping up. Dr. Samowitz, you have to come on up. We're going to do a joint Q&A. Anybody have a question?
Hi. The last two medications that were approved, do they address symptoms at all?
The question was, we mentioned that there were 2 disease-modifying therapies that were approved just last week. Do they address symptoms? They are disease-modifying therapies, so they're FDA approved to prevent relapses and possibly to affect disability progression as well. So they're to change the course of MS, but not for individual symptoms. Now, with that said, having taken care of a lot of people with multiple sclerosis, if you calm MS down, then your body is able to fix itself. The body is able to do a lot of good, but it can't do that when it's constantly being attacked. And so the idea of the disease-modifying therapies is to stop that attack somewhat. And so those medicines are similar to the other medicines that we already have approved in that they're for disease modification.
1992, you had no treatments. Now we got 14. Could it be that the pharmaceuticals seen a golden opportunity to make money?
So the question was, in 1992 we had no treatments, now we have 14, and I think the question was, are pharmaceutical companies making money off of this? And the answer is absolutely yes, but absolutely without the capitalism of drug development, we would still be like we were in 1992. I'd be looking out at this room, and instead of looking at people who are walking, I'd be looking at a room full of people who are mostly in wheelchairs. And so a lot has changed since 1992. The face of multiple sclerosis has changed. Part of that is earlier diagnosis. Part of that is disease modification. I wish I could say part of that was healthier eating habits and exercise, but I don't think we've gotten better at that in the United States.
I have a question. I have a question for both presenters. We've talked about Botox, the use of Botox. Is there any correlation between the use of Botox and an autoimmune response or trigger in MS?
I don't believe so. One of the things that they did with the Botox studies, and it's been around pretty long already. We've been using Botox quite some time already. We haven't really seen any kind of a resistance or a development of long-term tolerability to it. It's still still effective in the same patient.
The question was about an onabotulinum toxin type A brand name Botox. We do know that when you give a biological material, there's going to be a small percentage of people who are going to develop antibodies to that. And that's true for Botox, just like it's true for other medications. It's a very small number, especially as the medication has been cleaned up a lot over the years. So it's a much smaller number than it ever was before. And so you're talking about in really in small digits in terms of that. But we don't think of it as actually triggering something like multiple sclerosis. We don't think of it, we think of it as being a treatment for symptoms, but not a trigger for problems in multiple sclerosis.
Question here.
Could you speak to the new research that's going on for myelin replenishment?
So the question was about the new research that has to do with myelin replenishment. So if we think of MS as being mostly a white matter disease, but also gray matter, the white matter is made of this fatty substance called myelin. And as opposed to a regular electrical wire where it's on the outside, there's coating and the electricity goes on the inside, myelin has these gaps. We call them nodes of Ranvier. And what happens is the electricity jumps on the outside. It's actually called saltatory conduction, and because I'm not brought up in a Spanish household, I never thought about what saltatory conduction meant. I thought it meant salt, like sodium and potassium channels. But then I was watching Dora the Explorer with my nephew and niece, and she said, Diego, salta, salta. And I realized it's because it's jumping. So the electricity jumps on the outside. And when you have damage to the myelin, the jumping is just not as good. Or when you overheat a person, the jumping just isn't as good. That's why a person may start dragging their leg the longer they walk, or if it's hot outside. And so one of the things we want to try to do in MS is not just to stop an attack from happening, it's what can we do to build better myelin, to build healthier myelin going on. And so we've been trying for many years now. There was a product that was closest. Unfortunately, it had disappointing results. And so the next one is called RHIGM22, and we're still in early human phases. We're just not there yet in terms of the reformation of myelin. Some researchers are looking at older medications that are FDA approved for something else, totally something else, and just screening them and trying to figure out what else can help myelin formed. I don't think those are going to replace disease-modifying therapies. I think what they're going to do is the disease-modifying therapies are preventing you from having future problems and letting your body heal itself. These are going to give your body that extra push to help heal itself. So I think we will see those medications coming out soon, but we just don't have any that are right now coming out.
Can I ask a question of Dr. Kantor? Is there any issues regarding using the cholesterol-lowering drugs, the statins, and their impact on the myelin, or any neurological problems?
So the question was about the use of statins, the cholesterol-lowering medications that now have become blockbuster medications, have become generic, been used by millions upon tens of millions of people. About 10 years ago, there was a study that looked at interferon, and at that time, we were using a lot of interferons. Now we're using very little interferon. But remember, the first medication that came out for MS was a beta interferon. And it's different than the interferons used in like GI and in other kinds of fields. And what happened is people who were on interferon plus on a statin, they actually seemed like they got worse in some ways. And that really made us scared for a while. But then we started seeing other studies where actually statins helped prevent the shrinkage of the brain in people with multiple sclerosis. So right now, especially in someone without interferon, what we're looking at is most of us are saying it's actually a good idea to probably add on the statin. There's a study going on looking systematically at simvastatin, which has a brand name of Zocor, and they're looking at a high dose, 80 milligrams daily. And the idea is to see if maybe that simvastatin can actually help slow down the shrinkage of the brain that happens. Some of us, even before the results are out, are saying, well, reducing cholesterol is not such a bad idea anyway. Being healthier is not such a bad idea anyway. This patient's not on interferon, and they're tolerating the high-dose statin. Let me put them on it.
I use a catheter. And you think that the Botox going to help me out?
The question is using a catheter. Can I ask what kind you do? Self-intermittent catheterization?
Yes, about 10 years I've been doing it.
Okay. Some of the patients that start to develop more frequent catheterizations have to go to Botox to increase their bladder capacity. So if you're finding yourself catheterizing, more than every few hours, then we would probably use Botox so that you'd be able to store better in between catheterizations.
I'm doing it about 4 times a day, maybe 5.
That 4 or 5 times a day is considered pretty much the limit. That's as low as you can get, probably.
About 500 to 600.
That's very good, actually. You're doing fine with that. I wouldn't change anything. I mean, eventually you're going to have to catheterize. It's not like you can go without catheterize. And a normal patient would urinate more than 4 or 5 times a day. So you're actually doing quite well. I wouldn't change anything right now.
Okay, thank you.
You're welcome.
Later.
I've been in most, I believe, of the medication for the incontinence. And the last one I am is Merbetrix. It's supposed to be the best, right? And but still I don't think it helped enough, because many times I have urgency to go very fast to the bathroom, and I wonder if will be better the Botox or something else. I try also the needles in the feet, and it seems to help. But then the doctor that was giving it to me changed insurance, and he wasn't taking any more my insurance. That's why I stopped. But that seems to help.
Right. This is exactly what I was saying, is that the insurance companies have decided that they don't want to pay for these things, even when they do work. there's a large number of patients that the medications don't work, both MS patients and non-MS patients. And so when the medications don't work, and sometimes we have to get kind of innovative. We have to try combinations of medicine sometimes even, because some of them have different modes of action. But anyway, Botox is sometimes the next go-to treatment because it's putting the medicine in the target organ. And in that way, you don't have a lot of the side effects, and the patients do respond. Depending on how much Botox you need, but it's usually the next step. The problem is you have to be prepared for the small possibility that you might have to catheterize as well. And that's what scares a lot of people off. But it's a small risk.
Can you quickly recap on the effects on MS, or how does MS trigger the dysfunction of the bladder? What is it about is it the lack of myelinization on the spinal cord?
The question is, how does MS actually affect the dysfunction of the bladder? I put a couple slides up, but the reality is that it's not well understood. We don't even understand completely how normal bladder function is because it's fairly complicated. There's all kinds of loops and reflexes going from both the brain and the spinal cord and the sacral micturition center, and then getting out to the peripheral nerves. So there's a lot of interaction there that isn't really fully understood. We don't even have a definite explanation of what causes overactive bladder, this very, very common problem that affects 46 million Americans. We don't have an explanation of what the real cause is. So to try to overlay, why the MS patient is even worse and has similar symptoms, but it's worse, it's really hard to say how the demyelination. It's just the interaction between the bladder, the brain, the spinal cord, and the bladder and the sphincter.
But doctor, so my job as neurologist is to try to prevent the MS from causing future damage. What are the things that people can do to help their bladder by, are there foods or drinks that I know you talked about, but maybe it's a good idea to kind of reiterate kind of caffeine and how much it can irritate the bladder, and how there are things that we do every day, whether you have MS or don't, that are impacting how your bladder is functioning.
So, in terms of what patients can do, certainly there's certain irritants that we know for the bladder, alcohol and caffeine in particular. Some people are sensitive to food, some people are not. And so when we talk about spicy food, foods that are pickled, acidic foods, not everybody's food sensitive. So you have to sort of do an elimination diet where you take something out of your diet for 3 weeks and see if it makes a difference, and then reintroduce it and see if it comes back again. So not everybody can, not everyone is affected by diet as a irritant. We do encourage the being well hydrated. There's lots, and all three of us have mentioned that up here, I think, that it's important to be well hydrated, and then the urine needs to be sort of a light yellow color is sort of the best way to guide that. And then being cognizant of your voiding, being aware of it. If you haven't voided in like 6 hours, that's too long. You shouldn't wait that long in between voids. If you're catheterizing, you can get away with it because you know your pattern, but normal patients even urinate every 3 or 4 hours. That's considered normal. So you don't want to let your bladder get overly distended because it is a muscle, and if you get it stretched out, it's like pulling a muscle over and over again. Eventually that muscle loses its tone and it doesn't come back. It's like congestive heart failure. It just stretches and stretches and stops working effectively. So you just want to be aware of your voiding pattern. If you're having problems with incontinence, that needs to just be addressed as well, and sometimes the exercises do help. So that's about all I can think off the top of my head right there.
I hear that a doctor like Jackson is doing the stem cells. Do you know anything about that?
Yeah, I think the question was, are there stem cell research trials that are going on right here, even in Miami? There are some stem cell trials that are finally going on in the United States. The group in Miami is looking at stem cells. Probably in the United States, the The group that's looked the furthest has been the team in Northwestern University in Chicago. There's also a team in New York that's looking at stem cells. One of the interesting things is we have no idea what dose to use. We don't know how to give it. Should we give it into the vein? If you give a stem cell is a cell that can become other types of cells. So if you inject it into the bloodstream, well, you have to stop it from becoming a blood cell. Right? You want it to become a nerve cell or to become an immune cell. You don't want it to become just a regular blood cell. You don't want it to go to the liver and become a liver cell. So you're giving it other chemicals. So you're not just giving stem cells. So I do think that research is exciting about stem cells. My caution is just try not to be duped by people who are just trying to sell you a bill of goods where we have no idea, frankly, what they are giving.
This also applies in my specialty as well. I mean, stem cells are now the new big buzzword. And so in a lot of areas of medicine, they're trying to use stem cells for different things. Erectile dysfunction is the most current one. And right now, there isn't a lot of good science that shows that it's effective. So we're hopeful, it's optimistic, but it's not ready for prime time yet.
Okay, the same way that the MS affects the bladder, is there any chance that it may affect the stomach nerves?
So the question was just the same way that MS can affect the bladder can affect the stomach nerves. So one of the reasons why I kept showing that same image, which had like Dr. Google on it, is that almost everything you can think of goes in some way through the brain and spinal cord or optic nerves. Everything we do in life goes in some way through the central nervous system. We do know that the gut actually is the largest immune system in the body. It's also the largest nervous system in the body, is right there inside the gastrointestinal system. So there's definitely an interaction between what happens inside your gut and what happens in your brain. There are actually studies looking at specific probiotics, not every probiotic that you hear a commercial for, but specific probiotics that may one day be a treatment or a supplemental treatment for people with multiple sclerosis. There are people with MS, though, that also have other autoimmune diseases. So somebody with MS may also have ulcerative colitis or may have Crohn's disease. So there's sometimes that overlap that happens as well. And so I think if anybody's having any kind of intestinal problems, what they should do is make sure their neurologist knows about it, but also see a gastroenterologist.
Hi, I was diagnosed back in '83, and the problem I had, I couldn't control the urge to go to the bathroom. 36 years later, I need a catheter. So what changed that?
The question is, you were diagnosed 36 years ago with going too frequently, and now you're not urinating. You're not able to urinate on your own. I think probably your MS has also changed too. I mean, this is just the process of going from an overactive to an underactive bladder. And this is one of the things I was mentioning that you want to try to avoid by making sure you are able to go. But I think it's probably just the progression of the disease itself, where the bladder loses its muscle tone and it's going from a spastic overactive bladder to a underactive hypotonic bladder. But perhaps you can have some...
Well, another way is that it could even be not the progression of the MS itself, but if you take any muscle in the body and you don't use it the correct way, not your fault, but it's not used the correct way, and then what's going to happen is you're going to have disuse, atrophy, you're going to have loss of the muscle tone in that muscle itself. It's the same reason why, when we think about a cure for MS is going to be very different for somebody who's never had a symptom, for somebody who had family members with symptoms, for somebody who's had just one symptom, for somebody who's had lots of relapses, for somebody who's in a wheelchair. Person in a wheelchair, their legs already have what we call disuse atrophy a lot of the time. So you're not using your legs as much, and so what that means is there's not muscle there. Even if you could fix the nerves, there may not be muscle there enough to make it function. And that may have been a little bit what happened with your bladder as well.
There might have been dyssynergia too, which is really quite common in MS patients, where your bladder is trying to push the urine out against a partially closed outlet, and that overtaxes the bladder over time.
We have time for just a couple more questions. I have 3 of them that I see right now.
Hi, Dr. Kantor. My question is demyelation versus brain atrophy. as with the effects of MS. It seems we hear a lot about the demyelation. We don't seem to hear a whole lot about brain atrophy. And can brain atrophy, besides causing cognitive issues, also be responsible for physical symptoms such as problems with the bladder and so on? And is there any medication out there right now or perhaps in the works that will address brain atrophy?
So, excellent question. The question was about brain atrophy versus demyelination. And so let's talk about what those two terms mean. Myelin is that white matter covering, and demyelination is loss of that white matter covering. Brain atrophy means the loss of tissue, and brain, I think we understand what that means. So what happens over time is all of our brains shrink, just like all of our bodies shrink over time. I used to be 6 foot tall. No, but I'm shorter than I was beforehand, and as you know, people do get shorter over time. People's brains shrink over time. Somebody without MS, their brain shrinks like that. Somebody with Alzheimer's, their brain shrinks like that, faster. And somebody with MS is going to be closer to that person with Alzheimer's, and our goal is to move them closer to normal, or to even be within the normal. And some of our medications have been shown that the disease-modifying therapies actually can do that. They don't get that on their label because that's not what their FDA yet has said, well, this is a good enough way of measuring it. But we do have ways on MRI machines looking at it. Now, do we have other ways of doing that? Well, there is a supplement called alpha lipoic acid. And so alpha lipoic acid, what happens is you take 1,200 milligrams, so 2 of the 600 milligrams, you take it once a day, and that has been shown in small studies to actually reduce the shrinkage of the brain. I mentioned earlier that statins, there's some data that suggests that it reduces the shrinkage of the brain. There are other medications that are used for other things, that supplements that we think can help reduce the shrinkage of the brain. Now, you don't want to be taking too many of them because then you're spending a lot of money, but you also don't know what's helping and what's not, and you don't know when to start and when to stop, and you don't want to get side effects from things that are unproven. But that's a good idea to talk to your doctor about maybe trying 1 or 2 of those strategies to see if it helps. Your second part of your question was brain atrophy. You're correct. It can lead to cognitive problems because if your brain is shrinking, it means you're not thinking as much. But it could also affect some of your physical things. Now, normally it's not like suddenly your arm's going to stop working because of brain atrophy, because brain atrophy is a slow decline that happens. And our brains reorganize themselves. So if it's affecting the area that has to do with the hand, well, another part of the brain takes over and starts to control that area of the hand. So you don't normally see those kind of like stepwise things. But certainly, if you think about how people with MS may have more problems walking, some of that may be spinal cord atrophy that's going on over time, especially with progressive MS, and where that can impact someone's well-being.
How you doing? I'm sorry. I'm having trouble with my prostate, say for the uterus, for the rectum. So I wanted to know what should I do because I'm taking high blood pressure and sugar medicine. So what kind of function can I go through to get some type of satisfaction out of my rectum, if you don't mind?
I'm sorry. Did you say you're having problems with your prostate?
Yeah, having trouble with my rectum. To having, say, for it to stay erected.
Oh, you're talking about erectile dysfunction. Okay,
yeah.
I thought you said the rectum. And I was,
yeah.
Okay.
No.
That's not directly related to the prostate. So erectile dysfunction is a fairly complicated thing. It's a common problem. It has to do with probably both nerves and blood vessels. And very often, quite honestly, you end up with the same treatments regardless of where the problem is. But it's not necessarily the prostate that's causing that issue.
Excuse me for cutting you off, but I heard you say something about the urination. All right, I don't hurt or nothing like that. It's just that I might not urinate maybe 2, maybe 3 times a day, especially early in the morning. Say 2, 3 o'clock, 4 o'clock, something like that. I might wake up and have to go to the restroom. But after that, probably for the rest of the day, I might have to go maybe once or twice during the run of the day, and maybe that might be before 12 in the day or after 12 in the day where I might have to go to and use the restroom.
Right. Well, that's not too bad. It sounds like. Is that a problem? Urinating just those few times. I mean, you got to go sometime.
But
Everybody has to go sometime.
I don't drink. At one time, I'm a recovering addict. Okay, so at one time I drank a lot of beer, but now at this point where I can't drink the beer or doing drugs or whatever. You understand? So I had to back away from that. Right. So all I do now is just maybe drinks or juice or something like that. Maybe occasionally during the day.
Yeah, I'll tell you what. Why don't we meet after the session here? I'll spend a few minutes talking to you about your specific problems.
Sure. Any other questions? Any questions? There we go.
Hi, Dr. Samowitz. So my question is, do you ever see complications with self-catheterization? And if you do, what can you recommend to patients to prevent these complications?
So the question has to do with self-intermittent catheterization. You know, it's a technique that's been around for centuries. It's actually, it goes back to the Egyptians using papyrus reeds. And so it's something that, you know, we have a long history of doing. We're lucky that we could get to use sterile catheters now that are plastic and soft, because papyrus reed sounds pretty horrible. But in terms of complications, yeah, it's not free of complications, but for the most part, patients, once they get the hang of it, they go years without a complication. Once in a while, they might get a urinary tract infection. Once in a while, they might get a little bit of blood in their urine. Once in a while, they might develop things like a false passage, especially in a male, not so much in a female. But intermittent catheterization has a long history of being effective for many years without too many complications. And now that we have these disposable catheters that are really, and there's a lot of competition, I guess it must pay well because there's a lot of different manufacturers of these disposable catheters and they're hungry for your business. And they're pretty, they made them small, they made them very slippery with just water. They're hydrophilic, so you don't have to use a lubricant. They just plain water will lubricate it. And, but when I started out in training, people were reusing their catheters over and over again. Now we're just disposing of them. They're small, they're easy. Not a lot of problems. It's actually not a bad way to manage. And I have some patients that have severely overactive bladder that will have me use Botox with them so that they can do self-intermittent catheterization and they're happier that way. They're continent, they have time in between voiding or emptying their bladders, that they don't spend the whole day in the bathroom and they don't have that sense of urgency all day long. They're sleeping through the night. And so in some cases, we actually prefer that.
Any other questions? Why when I was standing right there, you didn't say something?
First of all, Dr. Kantor, you should mention your YouTube appearances. That's where I found you. Dr. Samowitz, I wanted to ask you, I'm a little confused about the therapy that you offer in your office for the Kegel. So what is the end result? If someone does it diligently, what kind of an outcome and how are they going to help their, how are they going to help themselves by doing this?
So the Kegel exercises go way back also, and they seem to be effective. There's certain reflexes that the Kegel takes advantage of. When you tighten your pelvic floor muscles, you send a reflex to the bladder to sort of calm down. It tells the bladder to shut up. So that's one. Two is you build up the muscle around the urethral sphincter, so that becomes more competent. It becomes more, it gets more stable. Okay, so that's that benefit as well. The big problem with the exercises is that you have to be diligent. You have to do them quite often. You got to do them correctly. And so we have a therapist in our office who uses the EKG pads on your bottom, and so that you can look at a computer screen to see that you're doing the right muscles. And then over time, you see that the muscles get more and more, they get stronger and more effective. And it's an old technique. It's one that we recommend as a first line. The problem I find is that patients just can't remember to do them enough. It's a kind of a hassle. It has to become part of your lifestyle. But they even have these chairs that you can sit on that are electromagnetic chairs that'll cause the muscle to contract, and those work. But they're not FDA. They're not covered by insurance. So yes.
But could you conceivably get off medications by doing these exercises? Are they that powerful?
Can you get off the medications without the exercises? We kind of treat this as the first line should be exercises, and when you fail that, we go to the medications. If you're already on medications, you might find that it's hard to get the same effectiveness with the exercises. I wish I could be more optimistic about the exercises. They're just not as effective as most patients want.
Okay. We're going to have to close the program. Thank you, doctors. Dr. Kantor, Dr. Samowitz, thank you very much.
Can I do a mic drop?
Can you do what?
Can I do a mic drop?
No. Okay, so again, thank you for being here today. Thank you for supporting MS Views and News, for all that we do. Thank you. Have a great day. Drive carefully.
Thank you.